some real talk. Good day, I'm Dr. Tia, and today I thought we'll have some chat about what has been rolled out by the Australian government, the federal government, and the Victorian government relating to accessing care from the pharmacist. Now, I am someone who I work as a general practitioner and I understand my role in the big pie that is provision of healthcare to our patients. But I think some people talk about working above their scope or to the limits of their scope as a way to probably put my patients in danger. Now, there's a thing called survivorship bias. Survivorship bias is where people reflect fondly. Oh yeah, back in the days, people used to have chickenpox and no one had any issues. And now kids are vaccinated for chickenpox. And what's the deal with that? Oh yeah, a lot of my friends have been having the pill with no issues or side effects, and now doctors want to hog the prescription and management of the pill because they just want us to pay for doctor fees. And what's the point with that? Survivorship bias is where, because you have survived an event, doesn't mean that everybody did. And the reason why we vaccinate kids for chickenpox is because not everybody survived chickenpox. Some people had complications, even death, from chickenpox. And the same thing with the oral contraceptive pill. The oral contraceptive pill is a medication that might seem simple and straightforward. But there are people who've had complications such as stroke from being inadequately counseled regarding their oral contraceptive pill. So when you, as a pharmacist, are claiming to be a history taker and a diagnostician, where do you even write notes? And are the notes regulated the same way as general practitioner record keeping is mandated by APRA and Co? And I feel like the Australian government is trying to fix the problem of not enough GP appointments by hiring other people who are not doctors. Pharmacists are not doctors. They play an integral role in the management of medications and things like that, but they don't practice medicine because they're not doctors. Like I think that to me is very straightforward. If you want to be a doctor, then you should go to medical school and be one. But when you're like, oh, I am a pharmacist, but I can moonlight as a doctor, I mean, that's okay for you, but I worry about the patients that you are looking after because they're getting care that might not be ideal. And so gradually there are these seemingly easy consultations that are being palmed off to the pharmacist because, when you're burning and itching when you pass urine, surely it's a UTI. Even blind Freddy can acknowledge that it's a UTI. But no, actually, have you considered it might be chlamydia? Have you considered that it might be a vulval cancer evolving? Yes, those things are not very common. Well, chlamydia is common. But those are differentials that have to be adequately explored and an adequate history explored, investigations coordinated, potentially, and discussion about management, safety netting, and understanding the patient, being able to review your documentation to ensure when the patient comes back for the third or the fourth visit with this UTI that you're checking in. But it's more like, no, the pharmacist should be able to now prescribe and treat diabetes. Really? I don't think that's good. You know, but yeah, I'm just a GP. I'm using that word just in jest because at the end of the day, like I understand my limitations. I understand that I have non-GP specialist colleagues, so I send liberally to dietitians and to endocrinologists and neurologists and all the ologists. But like I feel like when you are as a pharmacist wanting to be a diagnostician and to be a pseudo GP, just go to medical school. Go to medical school. Then you'll be a doctor. Then the standard of care will be such that you are a diagnostician and you manage patients adequately, independently, and all that. And this is not, I'm not, piling on pharmacists because I know not every pharmacist understands or agrees with the notion that a whole lot of these simple consultations should be managed by a pharmacist. Because I think it's true. And also, there is a conflict of interest there. Because when I prescribe a patient to start blood pressure tablets or to start, some cream or to go and get the QV, CeraVe Cetaphil lotion for their eczema, I don't then get paid for those things to be dispensed. There's no kickback. I know, controversial. People sometimes think that kickbacks. There are no kickbacks. I own no shares in Pfizer and all the GSK. Nah, there are no kickbacks. But as a pharmacist, my understanding is that a lot of pharmacists own the pharmacy. You are there telling the patient that, oh, you are having your fifth UTI in a row, and then prescribing the antibiotic, and then you get a cut from the selling process of the antibiotic, as in, I don't know how much you keep from selling drugs. Isn't that a conflict of interest? I mean, patients can go onto all the AIs and the chat GPTs and whatever and come up with diagnoses that they think they have and go to the pharmacist and have a conversation and then you prescribe. But I guess there's still a reason to go to medical school. There's still a reason to see a doctor. And so when patients are like, no, I've been seeing my pharmacist for managing my diabetes? Wow. I wouldn't do it if I was a pharmacist. I am a supervisor and I have registrars, which are doctors who are in training to be general practitioners. And even then, I'm still actively supervising them. And these are people who have hopefully been trained in being diagnosticians, management, blah, blah, blah. And I'm still supervising them because being a GP is not just you finish medical school equals you're a GP. Now, when you are in pharmacy, or pharmacy training, there is an understanding of physiology and how all that works. But it's a bit different to taking a history, examining a patient, managing things. And just because the 9 times out of 10 it was a UTI and you treated it and it worked out, it doesn't mean that there's no one out there suffering the harm of this experiment. And sadly, the people who tend to suffer are women, because statistically, the people who seek advice and present to my consultation room or the pharmacist are likely to be women, either discussing themselves, their family members, but they will likely be women. So if you're prescribing someone the 5th UTI treatment and they've attended multiple pharmacies and there's no record on what has been happening, and they've had chlamydia all along and they end up infertile with complications, it's women who suffer. Or the lady who's been prescribed the morning after pill and had a consultation in the middle of the baby formula aisle who might actually still be pregnant. or the lady who's been commenced on the oral contraceptive pill. And if a few more questions were asked, it would have been abundantly clear that it is a contraindication for her to be on that medication and suffers a stroke. Those are the repercussions that we worry about. I worry about this as a general practitioner, making sure I've asked all the questions, making sure that there's a safety net, making sure that patients understand when to be worried, when to present to the emergency department, or when we will both, me and the patient, need to tap out and see a non-GP specialist. So when people just want to take on this role without the responsibility, I worry for my patient. But I don't know. Is it too much? Do I care too much? Is it a problem? Should we just let everyone do what they want? What is the point of going to medical school then? Anyway, thanks for indulging me. I would like you to comment below and tell me. Have a good one.